When you start with one, always go step by step. The note has been already uploaded from the previous visit in today's. So go step by step, click the first one here in general, and you put your initials here. Okay, and then you close that. Okay, then you go for H&P, which is history of present illness. Make sure that you're putting a cardiac history first. Please clarify that the patient has no chest pain, no shortness of breath, no dizziness, no palpitations, no fatigue, no leg swelling. Okay, and if there is any back pain, shoulder pain, arm numbness, these are one of the most common symptoms that you will encounter in a cardiac setting. Also, sometimes patient has some back pains. You have to rule out if there is any aortic dissection is there or not, because the presentation of a chest pain will change in this time, because they will say that, oh, I have some tearing pain, or I have some severe onset of a pain just suddenly started. So you have to rule out that part. So clarify the chest pain. Just please write it down. If it's a chest pain, what kind of chest pain is it? What is the onset? When it started? How long it's going on? What's the severity? If there is any alleviating, aggravating, or associated symptoms with that, anything that he's doing or she's doing just to getting better, it is getting better or it's not getting better. So you have to see that through. Okay, it's important. And then if it's occasional, how many episodes he's been having a day. Okay, or if the patient is having any associated symptoms, or he has had the chest pain a week ago or 2 weeks ago, you have to write an approximate time, the duration of the symptom, and then what it led to. Then you're looking forward to another symptom is a shortness of breath. So shortness of breath is rest or exertion. How much exertion causes shortness of breath? If the patient is complaining of going uphill or downhill, okay, how many stairs he or she can climb that can cause shortness of breath. Okay, if a patient is having some house chores, if having some minimal exertion is causing shortness of breath, that needs to clarify. If there's a new onset, please mention that. How long it's going on. The duration is very, very important. If it is stable, worsening, not worsening, what's going on there, you have to write it down. Okay. Then about the palpitations. Palpitations can be of different kind. Patient can say that, I'm having some fast heartbeat, I have a blip in the chest, I'm having some irregular heartbeats, my heart is racing, okay? That you need to clarify. If I'm having some skipping heartbeats, that you need to address that. How long does it last? What's the severity of the symptom, and is there any associated symptoms with that? Okay. Then about the dizziness and lightheadedness, you have to clarify that. Dizziness can be cardiac, can be ENT related. Okay, so you have to rule out what's going on there, and then if it's a sudden onset, if it's a vertigo, or patient is having some when he stands up, patient is having some dizziness, or certain position or certain head movements. So you need to just clarify that. Then syncope. Syncope history is very, very important in cardiology, because aortic stenosis can give you syncope, IHS can give you syncope. There are a lot of things that can give you syncope. Dehydration can give you syncope. So the syncope needs to rule out that cold and flu can give you syncope because of dehydration and all. So you have to rule out when it happened, how it happened, what were the pre-symptoms and what are the post-symptoms. Okay, how long the duration. There's a total loss of consciousness or a partial loss of consciousness, whether any witness or not, okay? And what's the outcome, what the patient is having now, how long ago, correct history is needed at that moment, okay? Then about the fatigue, usual fatigue, more than usual fatigue, what's going on, is he been sleeping or not, okay? And taking some blood pressure pills, okay? Antihypertensives can cause, also statins can cause, so you have to rule out that, okay? If you change any medications, usually students are missing that part, that if you change some medications in the previous visit, that needs to be mentioned in the current note, the current visit, because if you're changing some statins in the past and you're writing that fatigue is still the same and there's no changes, then why did we change the medications? There's no Like, it doesn't make sense. Okay, antihypertensives can make you fatigue, can make you dizzy. So if you're adjusting those medications, if you're changing some medications, we really want you to mention that in the note that, hey, that's what we did and that's what we are looking forward to. Is there any change? If a patient says, I have a 10% change, yes, there is a change. Sometimes patient is unable to tell you that what the severity of the pain or the fatigue is now. Okay, so you can ask them in a different way. What do you think? You feel better than before? Do you have been exercising more often now? Do you think that, when you change your position suddenly, are you dizzy? Have been having some cramps at night? Have been sleeping okay? So there are the different ways of asking question to the patient. Take your time, don't rush. Okay, take the correct history. Then you go to the blood pressures. What's the blood pressure? Okay, what are the blood pressures are at home, and also if there is any changes with medications. Exercise. Patient has been having exercise, reports good exercise tolerance or poor exercise tolerance. Okay, then about the diet. Following the diet, not following the diet, cheating, not cheating, and then this headaches goes up here, not here, okay? This goes up here. First cardiac symptoms, then respiratory, and then others, okay? One by one. And then whatever you write in HPI, please mention that into the ROS, review of symptoms, okay? Review of systems, okay? So here, see here, there's a past medical history is missing here. So past medical history is here. So when you click the past medical history, it just allows you to write it down about the patient here, the cardiovascular, the gastrointestinal, and then the surgery. Okay, then the surgery if the patient has a surgical history or not. Okay, if the patient has underwent a recent surgery, please mention that in the surgical history. Okay, then you go to the medications. Medications, always write it down that the patient is, it's always a good idea to write it down 1 tablet daily. Okay, because when you will give this summary to the patient, and if they ask the medication list, it'll be much easier for you because they don't know what is POQD. They don't know POQHS. You have to write it down. Okay, please try not to use the abbreviations. Just use the normal words that patient can understand. So Androgel, aspirin, always write the name of the medication, the dose, the unit, and also the form of the medication at the administration. How the patient will take it. 1 tablet by mouth daily. 1 tablet by mouth in the morning, in the evening. Antihypertensives are used like once a day, twice a day, but please write hold if dizzy or standing blood pressure falls less than 110, like in clonidine case. Clonidine has a side effect of orthostatic hypotension, okay? So in that case, you write it down less than 120, less than 130, because that medication is only used for labile blood pressures, like if your blood pressure goes to 170, at that moment you use that, okay? So all these things needs to be mentioned. Please check that there is no double medication. So if you see here that if you want to change the medications, okay, if the patient is not taking, let's say patient is not taking the Benadryl, so you select the medication here, okay, and you go change or DC. Do not edit, please. Okay, so change, you have to change you have to select 2 days prior, okay, and then you say okay. So this medication will remain in the chart, okay, in the previous charts, but if you will select today's date, it will remove from the old charts. So we will not have any history of patient taking these medications, okay? So only 2 days prior to that. If you want to add something, you don't need to add any date because it's for today, okay? But it's only for the discontinuation of the medication or change in dose that you have to select 2 days prior to that. Okay, so this one is fine. Then you say allergies. Allergies are very, very important. You have to write about the allergies. What was the cause? What did it cause? What was the adverse effect of the medication? Okay, then you write down here. Social history is very, very important. Please write it down. Okay, is there any smoking? How much cigarette is smoking? Okay.
No PPD.
No PPD. Okay, family history is important here because family history, the genetics and everything, if a patient has diabetic family history, then he is like, he can have that if he's not following, okay? So this thing, again, remember, HNP or HPI, whatever you mention, any symptom, any disease, any problems in the history of present illness need to be addressed in ROS. Okay, and relevant physical examination. Physical examination you can ask to Dr. Ben-Zur, okay, and Dr. Ben-Zur will tell you that, hey, I found this thing in this patient. If he forgets, then you can ask him that, hey, this is what it is. Vitals, blood pressures, regular, irregular pulse. You have to write down that, please. Okay, then weight, height, and temperature. 3 vitals needs to be mentioned in the note. Okay, then if the patient is 100, see here, it's his regular heart rate. So 100 and above, it's sinus tachycardia. Okay, 60 or less, 60 is okay, but less than 60 is bradycardia. So you have to mention that. If the patient is in 40, then it's a marked sinus bradycardia. Okay, if the patient is having 120, which is hardly it happens because otherwise he'll be in a flutter. Okay, it's irregular rhythm. Okay, you have to ask AFib is irregular rhythm. So in sinus tachycardia, like 102, 103, 110, at that time you have to mention it here, sinus tachycardia. Okay, and that sinus tachycardia part will go in your assessment also, that you did notice that patient was in sinus tachycardia. Was the patient symptomatic or not? Okay, so here you go. So Ekg Echo studies will be entered whenever if you know that there was a study done today, wait for the study. Okay, the indications is very important. Okay, indication is very important. At that time, when you see the indication there, then you want to do something in the note. If says a left carotid bruit, so you don't have any symptoms, patient may be asymptomatic. But if you see, then you didn't mention about the shortness of breath, and a study shows the indication was occasional shortness of breath, you have to write it down. Even you write it down, patient has a history of shortness of breath with moderate exertion, it has been stable of late. That clears it. That is enough. Okay, here then you wait for the studies and you interpret that studies and use that results in your assessment. Diagnosis codes you don't need to worry about. Preventative, okay, so preventative medicine, you always ask 3 things in male, except in female, except the prostate. Okay, so because they don't have prostate. Okay, so here colonoscopy, endoscopy, okay, bone density for the female, flu vaccines for both, okay, pneumovax and Zostavax for both. Okay, in male you will ask for prostate and prostate PSA and prostate examination, and female you will ask the mammogram. Okay, and then you close it, and then we will switch to the diagnosis. So diagnosis we will put it, but you have to mention it if the patient is having any chest pain here. So you rule out mild chest pain, moderate chest pain, occasional chest pain, intermittent chest pain, new onset chest pain. You have to write it down that. Okay, what do you think? Ask Dr. Ben-Zur that what do you think? It's an atypical chest pain, it's angina, it's crescendo symptoms. What are we doing for that? If Ekg Echo is normal, non-significant, then you write it down, possibly likely secondary to whichever word you want to use. Can be like musculoskeletal, can be GI, can be stress related. You have to rule out. Then after you write it down that you have clearly as Dr. Ben-Zur, you're writing down that you just like you cleared that patient that he does not have any possibility of pulmonary embolism or any other cardiac issues. What we will do a cardiac stress test, or you can say the exercise stress test, just to rule out cardiac etiology. Okay, then you need to mention it here. Always write it down, the EF of the patient, and is there any major abnormality that you noticed in echocardiogram, like like murmurs, not the murmurs you will see in the physical examination, but here regurgitation and valvular regurgitations or dilatation of the aorta or EFS decrease, some other akinesis or some diastolic dysfunction needs to be addressed in chest pain and shortness of breath. Dizziness, you have to write it down that the blood pressure is okay. If the blood pressure is low, okay, is there any orthostatic changes, okay? And in later run, like, they do a carotid artery duplex scan that rule out that if there is any stenosis or not, okay? Then you write it down non-obstructive, or if there is any blockage, then you write it down there is this much of a blockage that we noticed, okay? Then hypertension, always write about the LVH, the left ventricular hypertrophy. Then we do a renal artery stenosis, if there is or not, and then there is an abdominal aortic aneurysm or not. 3 things needs to be mentioned here one by one. According to the studies, if they're done, you can write it down. Then what we are doing, if there's any medication changes, what you're recommending the patient with 110, 120, usually blood pressure in a normal setting. Some of the patients, like, aortic stenosis patients, what they happen, they tend to have, like, we can't have them at too low of a blood pressure, but in a specific setting, usually we want them to be on the low side, but in a specific setting that, patient has a history of syncope and passing out with low blood pressures, so we want their blood pressure to be in 120, 130, like that, okay? Then hyperlipidemia, LDL, HDL, what you're doing for that, and a low-fat diet is recommended. Okay, if there's any valvular problems, please don't write. If there's a trace regurgitation, doesn't make sense. If it's mild, moderate, severe, please mention that, what we are doing for that. And these assessments, like, there are a couple of templates that you can use it here if you want to. Let's go to the diagnosis. Let's go down there. Okay, the assessments here. You can use them if you don't want to use them, because this is one by one by one. There'll be too much clicking, but you can type it, you can free text it, and they'll be okay with that. Whenever you want to change, whenever you want to say, okay, save, and then okay. Otherwise, it can happen that you will lose whatever you write. Okay, so that's what matters, okay? And that's okay here. Okay, in other symptoms, so first cardiac symptom. Okay, in others, you can write it down. Patient has a COPD, patient has a tobacco disorder, patient is having some osteoporosis, some hypothyroidism. So what was it? TSH, last TSH, and did you do anything? Did you change any medications at that time? And if the patient is having any palpitations on synthroid dose or lower or less, like lower or higher doses of that, you need to mention that. And then also again, any other symptoms needs to be addressed in the others. Okay. And one more thing I was telling Sa that, if a patient has some history of pulmonary nodules, right, and Dr. Ben-Zur is asking him to have a CT in 12 months, and the study was done in 2009, and now we are in 2012, the study is still going on. So you have to ask the patient, did you go for a CT, or who is following you for that? If nobody, then Dr. Ben-Zur needs to know that part, so that we will send the patient just for our sake, just to be on the safe side, to make sure that there's nothing wrong going on. Sometimes patient, they have a CT scan, and sometimes they think that there can be a localized infection, and that time it's like they saw something, and then a couple of years later they did it again, repeat CT, and there was nothing. So there was an inflammatory process there, which just resolved. So, but if there is a pulmonary nodule, especially in a patient with a smoking history, you better be careful. Okay, so always remember HNP, okay, HPI, okay, then go to the ROS, and then whatever you mentioned needs to be addressed in assessment. And the plan any medication changes. If you write a new medication, okay, then you say put a plan here, and then you say medication changes, not medication changes. So usually when you write about the medication, you write it down like this. So let's say if I'm giving a medication to the patient, so say trial of Lipitor, okay, so 40 milligram tablet, okay, then say sig, okay, you write it down, 1 tablet And then you mentioned it, the patient was informed the possible side effects of the medication, and he was informed, he was advised that he will discontinue the medication or call me immediately if there is any change or if he has any adverse effects. Okay, then you say, okay, always remember medication, dose, units, form, and the administration. Okay, say, okay, and if you are prescribing any medication which is like Ambien, diazepam, benzodiazepines, or any, like, you know, anxiolytics and all, please write it down that the patient is advised not to exceed this amount of medication a day. And sometimes you need to mention that the patient is advised not to drive after taking this medication for 1 to 2 hours, because some of them, they can cause drowsiness, like Xanax can cause drowsiness, and while driving, you know, they can cause harm to themselves and to others as well. So that needs to be mentioned in the. Always take a correct history, please. Okay, what they are here for. Please read the chart before you go into your room. Please know their names. You knock the door. Hello, my name is this, and it's a pleasure to meet you. How can I help you today? Okay, then they will already start. They know you are new to them. They are not new to us. So they will start telling you, oh, I'm having some chest pain last time, and you know, Dr. Ben-Zur gave me some Dexilent, and it's resolved. It's amazing. It's so good. And sometimes patient is really, really, like, in a bad shape and says that, oh, nothing happens. Then you rule out what happened. Then you ask them, did you notice any change? If there is any 5% change, 10% change, then you never know. Maybe the medication is working and maybe it's not working. So that later you need to discuss with Dr. Ben-Zur or whoever you present to. But correct history is much easier to analyze and giving a correct diagnosis to the patient, because you're not missing. In a cardiac setting, if a patient has a coronary artery disease, always ask the patient, always check the chart if there is any PET scan done or not. Okay, it's a nuclear cardiac imaging. Sometimes it can be called as a regadenocyte PET scan, myocardial perfusion PET scan, Lexi scan, anything, adenosine PET scan. If this is mentioned, please mention that to Dr. Ben-Zur while presenting. That patient has had this test in the past and it showed that it's low probability, high probability, and is the patient is having any chest pain, shortness of breath, stable, worsening. Patient wants to do something, doesn't want to do anything. You know what I mean? That needs to be mentioned in the presentation. And also, whenever you're writing your notes, in the end of your note, please reread your note. It should make sense. It should be like a story that you're writing it. That, you know, patient was here for chest pain. I thought that the chest pain was just gastric, okay, GI related, okay. We gave him a Dexilent, okay. We monitored the patient in the clinic. Patient felt great, okay. Patient left. I think this is of the GI related, and then after patient was given this medication, we will follow him in a couple of days or weeks or 10 days, okay. Whatever Dr. Ben-Zur says at that time needs to be followed, and always go through. So again, chest pain has a quality, intensity, onset, alleviating, aggravating, associated. Last episode, shortness of breath has intensity, severity, there's no quality there, okay? Pain has a quality, okay? Then you write it down the scale 1 to 10, okay? Sometimes patients are unable to give you those numbers, but you can ask them, do you think it's very minimal, mild, moderate, what do you think? So that's important. And then you go for dizziness. Dizziness has no quality. Then you can write it on it severe, moderate, intermittent, occasional, when the patient is having it. You need to write that why. What aggravates it? What precipitates it? That you need to mention that. Sometimes patient has no aggravating factor, no precipitating factor, and sudden onset. Then you need to write sudden onset of that. Then fatigue, also we discussed. Also leg swelling, you have to write it down in the HNP that, you know, the leg swelling occurs in the morning or in the evening, because it changes the diagnosis. In the morning it is related to, mostly it's related to the renal insufficiency. In the evening it's more cardiac. Okay, So that needs to be mentioned. Also, sometimes patient has peripheral vascular disease, which and the patient comes with leg pain on while walking or with exertion. So claudication is only uphill, not downhill, because uphill is lack of blood supply, right, to the certain area, and that causes the ischemic part, that causes the pain, because that's what the patient is suffering from. And when it goes downhill, it feels great. So you need to mention that in the claudication part, the patient walks uphill. For how long does he walk? And then after, how long does it take to get rid of the problem? Does he have to rest, or it continues and pain resolves? Sometimes patient will, you will have that kind of presentations also. The patient will come with that issue. But always remember, it's very, very important. On the top of that, always starts from head and neck, head to top. I always start with the patient with any headache, visual changes, any tinnitus, any ear problems, any pressure in the ear. Sometimes pressure can be because of hypertension. Okay, any jaw pain, very, very important in cardiology. Need to know if there is any jaw pain. Okay, any neck pain. Okay, any postnasal drip, because, for example, Januvia can cause postnasal drip. I'm just giving you an example. So you need to write it down that if there is any medication that can cause. Okay, then you go for chest pain. Is it chest wall pain? So you can rule out costochondritis. If it is anginal pain, patient is having anxiety issue that is causing chest pain. So you need to rule out that part. Chest pain. So we went through all the chest cavity. This is also a chest pain. This is also a chest pain. Back pain also comes in a chest cavity. So you need to address that. Any shoulder pain, shoulder blade ache, any shoulder issues, any numbness, tingling in the extremities. Do you feel hand stiffness? Why? Okay. Do you have any pain here? Do you feel cramps? You need to mention that. Okay. Then you go to the stomach. Okay. Any GERD, heartburn, any GERD-like symptoms, any pain here, epigastric, spleen area pain, anywhere, left upper quadrant, right upper quadrant pain, epigastric pain, vague abdominal pain, paraumbilical pain. All pains needs to be addressed. Okay, bloating, any abdominal symptom needs to be mentioned. Then you go to the urinary symptom, any recent infection. Okay, and then you mention that urinary frequency, any burning sensation, all UTI symptoms you need to ask that. Any pubic, suprapubic pressure, you have to ask. Any flank pain in UTI, very common. Okay, any leg pain, any testicular pain, anything that you can run, anything that you can ask, please ask the patient. Thigh pain, hamstring pain. Okay, any pain with exercise. Okay, does it resolve when you rest? Okay, any pain in the lower extremity, like you asked about the claudication, that's okay. But any cramping, like statins can cause cramps. Okay, lack of potassium can cause cramps. So you need to rule out that. That's what we order labs. Okay, that's what I want you guys to mention the lab results in the assessment. If there's any changes, low potassium, hypokalemia, low sodium, hyponatremia, patient is advised to hold the free water intake to 1 liter a day. Repeat labs advised. We will follow the patient carefully, because if there's any changes, any further drop, patient may need a nephrology consultation, because low sodium can cause a lot of symptoms, neurological basically. Okay, so you need to rule out that part. Okay, foot. Okay, always ask if there is any tropic ulcers or not. Okay, check for the gangrene if the patient is diabetic or not. Any swelling, anything that you can find in callus, anything that you need to check it. So even sometimes maybe you can ask the patient, will you please take off your shoes, and I need to check if the patient is diabetic. Usually they will tell you, no, I don't have any problem. Okay. Also rule out the DVT. Also check the signs of DVT. Patient can come with a severe pain, cellulitis, redness, like color changes, anything, any hot, or the signs of infection. 5 signs of infection needs to be ruled out there. Okay. And then again, we forget about the back pain. So back pain, upper back pain, mid back pain, lower back pain, does it radiate to your legs or not? So all these things that you have to write about: the symptom, onset, how long it's going on, what was the duration, did you do anything, did you see any doctor, are you taking any OTC, are you taking any medication was prescribed by anybody doctor, do you think it's worsening, do you think it's getting better? Okay, is there anything that you want to add something? And in the end, always ask the patient, was there any medication changes since your last visit? Did you see any other doctor during that time period? Did they change any medication? Did they adjust any medications? Usually patient, or we forget to ask that part, and that affect everything. If the patient was an antibiotic, for example, okay, the patient forgot to tell you, and then you see the patient isn't coming in, and the INRs are just labile. What happened? Patient's INRs will perfectly fine. What happened now? Oh, I forgot to tell you. I'm on an antibiotic. Great. So that needs to be addressed. And at the end, when you leave the room, thank you very much. Is there anything else that I need to know, or you have anything to tell me before I leave this room? It's nice to meet you. Thank you so much for coming in. That's it. Good?